Fibrous dysplasia of bone in children, pathophysiology, clinical aspects, treatment, and long-term prognosis. Fibrous dysplasia of bone is a genetic disease caused by a mutation leading to an increased synthesis of the protein G that stimulate mitosis of the preosteoblasts that assume the phenotype of fibroblast-like cells. Only few preosteoblasts reach a more mature stage, forming thin and irregular bone trabeculae, assuming a Chinese writing pattern, with scanty mineralization like in osteomalacia, and structural anomalies leading to bone fragility. Dilated vascular channels are present in some tissue areas, bound to bleed if injured. Since the mutation is postzygotic, the result is a mosaic state in which normal and dysplastic bone coexist. Fibrous dysplasia of bone may be classified in monostotic form, polyostotic form, McCune-Albright syndrome, Mazabro syndrome. The most frequent clinical manifestations of the disease are pain, swelling, deformity, limp, and fracture. Fractures are rare in monostotic fibrous dysplasia, but frequent in polyostotic fibrodysplasia, McCune-Albright syndrome, and they are very frequent in McCune-Albright syndrome patients with phosphaturic factor. LIT has shown that the fracture peak in those patients is between 6 and 10 years of age. The most frequent fractured long bones in our patients were femur, tibia, humerus, fibula, and forearm. Radiology is the first choice imaging for fibrous dysplasia diagnosis. CT scan gives a better definition of FD lesions, but it is best indicated in craniofacial and ribs localizations. MRI gives an intermediate to low signal intensity in T1 and an intermediate to high signal in T2. It is useful to identify FD lesion limit within a bone, but not very useful for differential diagnosis of monostotic fibrous dysplasia. Bone scan usually shows an increased uptake, and it is very useful to evaluate skeletal spreading in polyostotic fibrous dysplasia. PET-CT scan has its main indication when a malignant transformation of FD is suspected. Monostotic form accounts for 70–80% of all FD cases. It usually has a delayed clinical presentation. It runs frequently asymptomatic, and it includes localized and diffuse forms according to the extent of the lesion within the affected bone. When symptomatic, it becomes clinically manifest by pain, swelling, bone deformity, and fracture. The most frequent localizations are femur, tibia, humerus, and ribs. And here you can see the list of the most common differential diagnoses of monostotic forms. We believe that bone biopsy is indicated in these cases more than imaging screening to make a quick and correct diagnosis. The treatment of choice in symptomatic monostotic fibrous dysplasia is curettage and bone grafting associated either with internal fixation or with plaster cast according to its localization. Wide excision, bone grafting, and internal fixation may be indicated in particular cases, like in this historical case of our collection, fixed by a dual fibular autograft plus Anders nailing. And now question case 1. AP radiographic view of the right lower leg of a 12-year-old boy with worsening right ankle pain started 2 months earlier. No local swelling, redness, fever, and normal blood tests, with tenderness on the lateral aspect of the lower leg. What is your differential diagnosis? Would further imaging, in your opinion, be helpful for a differential diagnosis? Would it be appropriate to indicate bone biopsy after this radiograph? What kind of bone biopsy do you advise? Would it be possible to look for FD mutation on the paraffin-embedded tissue? The histopathologic diagnosis was fibrous dysplasia. A bone scan excluded polyostotic fibrodysplasia. Curettage and bone grafting was proposed, but the family wanted to have another opinion, and the boy was lost to follow-up. He came back 18 months later with a huge blown-up ground glass lesion sparing both distal physis and epiphysis. His lower leg was swollen and anterolaterally bowed. What treatment do you advise at this point? We performed an intralesional corrective osteotomy stabilized with the antegrade introduction of 2 ender nails to spare the still active physis, and 3 years later, further cystic expansion with partial recurrence of the deformity is evident, as well as 5 centimeters of leg length discrepancy. However, the upper part of the lesion showed increased mineralization. Lower limbs were fully grown. What treatment now? We performed Ilizarov leg lengthening at the level of the normal proximal tibia, unfortunately complicated by a regenerate fracture fixed with an interlocking intramedullary nail. 2 years after intramedullary nailing, fracture healing and uniform sclerotic aspect of the FD lesion are visible. Both polyostotic form and McCune-Albright syndrome account for about 20–30% of all FD cases. They usually have an early presentation, they rarely run asymptomatic, and their chronologic progression up to 90% of skeletal involvement, as assessed by bone scan, are the first appearing are the craniofacial lesions by 3 years of age. The second appearing lesions are the extremities lesion by 13 years of age, and the last appearing lesion affect the axial skeleton by 15 years of age. In McCune-Albright syndrome, endocrinopathies may become clinically evident even before skeletal lesions. Typical is precocious puberty in both female and male patients. PFD differential diagnosis must be mainly made from multiple non-ossifying fibromas, multiple enchondromatosis, and juvenile Paget's disease. In PFD McCune-Albright syndrome, skeletal involvement may be diffuse. Femur and tibia are affected in almost 80% of cases, and they may develop typical deformities. Skeletal deformities may progress and change their pattern during growth, mainly in femur, as you can see here, and risk factors are young age diagnosis, McCune-Albright syndrome, rapid spreading of fibrous dysplasia lesion from the cervicotrochanteric area to the diaphysis, shaft cortices thinning, calcar osteolysis, and cystic-like lesion in the intertrochanteric area with calcar erosion. And you can see here another case of typical progression. In a cohort of patients with polyostotic fibrous dysplasia, McCune-Albright syndrome, published by us, scoliosis was present in 33% of cases. In 21% of cases with scoliosis, spine was involved by FD lesions. Scoliosis was significantly more present in patients with pelvic involvement and pelvic obliquity. Fortunately, scoliosis was not evolutive in 77% of cases with short curves, but owing to the high prevalence of scoliosis, we believe that spine must be included in the clinical radiographic survey of PFD McCune-Albright syndrome patients. Medical management of fibrous dysplasia. Bisphosphonates have been the first drugs used in this disease. As you know, they bind to hydroxyapatite crystals by inducing osteoclast apoptosis. They are active on pain control by intravenous administration, but they are not effective by oral administration. They have no effect on limitation of FD lesions expansion, and they do not bind to the poorly mineralized FD matrix as we have shown in this histologic study. Denosumab has been recently used in McCune-Albright syndrome treatment. Denosumab is a monoclonal antibody to RANKL that prevents activation of RANK receptors present on the surface of mononuclear preosteoclastic cells. It blocks FD lesions evolution and induces marked mineralization of FD matrix. However, when stopped, osteoclastic activity resumes, with FD lesions recurrence and consequent life-threatening severe hypercalcemia. Experimental studies in mice with FD showed that an anti-mouse denosumab induces normal bone formation within F deletions and prevents the formation of new F deletions in young mice. An association of denosumab with zoledronic acid is suggested to prevent the dangerous increase of serum calcium level induced by denosumab discontinuation as well as FD recurrence. Studies on this combined treatment are in progress on FD mice. Burosumab is a monoclonal antibody to phosphaturic factor FGF23. It is effective in patients with X-linked hypophosphatemia caused by FGF23, as shown by Carpenter and co-workers. But clinical trials are in progress on McCune-Albright patients with FGF23 at NIH USA. At present, McCune-Albright patients with phosphaturic factor are routinely treated by oral administration of calcitriol and phosphates with limited effects, at least in our experience. In severe cases, the first deformity that shows up after the child starts to walk is Coxa-Vara with Trendelenburg limp in unilateral and waddling gait in bilateral cases. And the family is worried. And this is our question case 2. This is a 3-year-old limping child with impending Coxa-Vara on the left, 6 months after the child started to walk. What to do? Observation, restriction of walking, brace, surgery. Restriction of walking was not effective. The child is now 3-year-old and he walks with a marked waddle gait. Very often he refuses to walk. What to do now? Still observe the case, brace application, do surgery in this case, what kind of surgery? We performed bilateral valgus osteotomy stabilized with a 90 degrees Sinton's infant blade plate. There was a marked improvement of the child's gait. For how long do you think that correction will last? Do you expect complications? "18 months later, there was a bilateral 10 degrees loss of the neck shaft angle correction and a stress fracture with a 25 degrees varus femoral deformity below the right plate. There was also a moderate limb recurrence. What to do now? We removed the right plate and we corrected the femoral deformity that was fixed with 2 K wires and a hip spica cast. But 14 months later, recurrence of Coxa-Vara and varus deformity below the left plate are evident. What to do now? The left plate was also removed and the child followed up every 3 months. His condition remained stable up to 6.5 years of age, when further loss of the neck shaft angle and impending Shepherd-Crook deformity became evident, together with marked limp. What treatment now? Brace, surgery? What kind of surgery? We performed one-stage correction of both Coxa-Vara and Shepherd's crook deformity on the left and 8 months later on the right. Between the two intramedullary nailing, the boy manifested precocious puberty with a marked growth spurt. Correction was fixed with an adult humeral nail. The boy is now 8.5-year-old, and the left nail has become short with Coxa-Vara recurrence on the same side. And now a brief question, case 3. Do you think that the new 130 degrees unculated orthopediatrics cannulated infant hip blade plate could guarantee a long-lasting correction in comparison to the 90 degrees Synthes hip blade plate in children with early Coxa-Vara? According to our experience, the answer is no, as you can see in this radiograph, in which a 20 degrees loss of correction of the neck shaft angle occurred on the right 6 months later, when the left plate was replaced with an adult proximal humeral nail with a partial restoration of the primitive 130 degrees correction on the left. And these are our indications for surgical treatment of PFD McCune-Albright syndrome. In symptomatic upper and lower limb cases, as well as in fractures. In all cases, the weak FD bone must be reinforced by an intramedullary device. Bone grafts are useless because they are resorbed and replaced with FD tissue. Never use peripheral plates with the exception of either Coxa-Vara in infants or as the first stage of a two-stage procedure in severe femoral deformities with Coxa-Vara equal or less than 90 degrees. Plating is always a bad evolution, as you can see in the plated fracture here below. And I will show you now our personal series of lower limb exaggerated intramedullary nailing in children and adolescents. We had 21 consecutive patients whose age and diagnosis ranged from 2 to 12 years, with a mean of 5.8 years. They were all initially treated by us with either femoral or tibial intramedullary nailing from 1998 to 2017. There were 29 femurs, including 24 deformities and 5 fractures, and 14 tibias, including 11 deformities and 3 fractures, for a total of 43 operated cases. There were 10 males and 11 females, 16 McCune-Albright and 5 polystotic fibrous dysplasia. The mean age at first intramedullary nailing was 9.3 years. The mean age at the last intramedullary nailing was 16.5 years. Intramedullary nailing was repeated during growth with a mean of 2.13 femoral and 1.5 tibial intramedullary nailing for each limb. Either titanium elastic nails or adult humeral nails were used in children, whereas regular unreamed femoral nails and unreamed tibial nails were used in adolescents and fully grown lower limbs. When neck shaft angle is equal or less than 90 degrees, one-stage correction by intramedullary nailing with a cervicodiaphyseal nail is not feasible for 2 reasons. In these cases, a more medial entry point is needed for positioning the proximal fragment into valgus correction. Injury to the diracular vessels is likely to occur with consequent avascular necrosis of the proximal femoral epiphysis. Second reason, by reaming the proximal femoral fragment close to the greater trochanter, a fracture is likely to occur with decreased nail stability. We performed a two-stage procedure in 6 type 6 femoral deformities, and you can see here a typical case with a severe coxavara with a neck shaft angle of 50 degrees. 2K wires are introduced before starting the operation to orient the position of the blade of the plate and the level of the osteotomy. Once the osteotomy is performed and the blade of the hip plate is well fixed into the femoral neck, the deformity is reduced, the blade is maintained close to the diaphysis with a bone clamp, and it is fixed with obliquely oriented screws to improve the stability of the screws themselves. At the end of the procedure, the neck shaft angle measures 120 degrees. We obtained a correction of the neck shaft angle of 70 degrees. The second stage is carried out 3 or 4 months later. You can see the positioning of the and the reaming of the medullary canal to position in this case the proximal adult humeral nail that is stabilized with a distal locking screws and a proximal spiral blade. And these are the main symptoms and signs before surgery. And this is the list of the complementary surgeries we performed at any time during growth associated with intramedullary nailing. Proximal valgus femoral osteotomy, and we saw some cases before. Distal femoral and proximal tibia epiphysiodesis for lower limb length discrepancy equalization. Distal medial femoral and proximal medial tibial epiphysiodesis for genovalgum correction. Distal medial tibial epiphysiodesis for angle valgus correction. And femoral or tibial mid-shaft osteotomy for acute deformity correction in particular cases, like in this case of lower limb length discrepancy, because when long bones are totally affected by fibrous dysplasia, lengthening procedures, as you know, are not feasible. At follow-up, results were evaluated by a combination of Gill and Jung scales modified by us, by adding more clinical and radiographic parameters as shown in the following table. We had 8 excellent, 6 good, 3 fair, and 4 poor results. At follow-up, lower limbs were fully grown in all the patients but one. The mean age at follow-up was 22.3 years. The mean length of follow-up from the last intramedullary nailing was 6.1 years. And families were pleased with the good quality of life of their children within the intervals of time between subsequent intramedullary nailings. No more fractures, neither painful deformities were observed. We believe that titanium elastic nails should be used only in children younger than 5 years of age. Maltracking, cutting out, long operation time, high X-ray exposure of both patient and surgeon, and lack of prevention of either fracture or deformity are all complications due to the thin corticals of both femurs and tibias. For this reason, we believe that either adult humeral nails or the new generation of pediatric femoral nails should be used as soon as they fit appropriately into the femoral and tibial shafts. And these are two patients who obtained a good result. And these are two patients who had a poor result. The patient on your left is the youngest patient at follow-up, not yet fully grown. Both patients were lost to follow-up for many years. And this is the list of complications. We had one femoral subtrochanteric osteotomy non-union with nail break, one femoral refracture after titanium elastic nailing, two fractures below the hip plate in a two-stage procedure, and two acute loss of neck shaft angle correction. We also had one massive intraoperative femoral bleeding, two distal locking screw loosening, and altogether 25% of major and 7.4% of minor femoral complications. We also had one tibial refracture after nailing and three distal locking screw loosening. 7.6% of major and 23% of minor tibial complications. Overall, we had a very high rate of complications. So, in conclusion, fibrous dysplasia of bone has a broad spectrum of severity, ranging from localized monostotic forms to diffuse polyostotic forms associated with endocrinopathies, as in McCune-Albright syndrome, that may further increase skeletal fragility. Differential diagnosis of monostotic forms from other skeletal tumor-like and tumoral conditions may be sometimes difficult. In those cases, a bone biopsy, more than an imaging working out, may help to make a correct and quick diagnosis after the first radiograph. Some diffuse monostotic forms have a difficult treatment and a poor long-term prognosis. McCune-Albright patients with FGF23 phosphaturic factor have the worst prognosis for both fracture prevalence and bone deformity progression. In many of those patients, even excellent surgical results may deteriorate in time and require an early revision surgery. In our experience, early surgery based on intramedullary nailing techniques offers long-term satisfactory results in the majority of PFD-MIS patients, although poor results should also be expected. In young children, intramedullary nailing must be repeated during growth and families must know that the risk of surgical complications is high. Peripheral plates must be used only in particular cases because the risk of complications is very high. Curettage and bone grafting are only indicated in localized monostotic fibrous dysplasia. The development of mouse models with FD mutation is an important tool to elucidate the natural history of the disease and to design and test new therapeutic strategies. We believe that in the next future, thanks to this experimental FD mouse model and to a better understanding of the pathophysiology of the disease, new drugs will improve the quality of FD bone and will help surgery to provide a better long-term prognosis even in severe McCune-Albright syndrome cases. Thank you very much for your attention.